cardiovascular risk and lipid management in Indian patient. Key message from the Lipid Association of India 2024 statement. So now the epidemiology of atherosclerotic cardiovascular disease is far different from the Western country in the India. So Indian developed ASCVD about a decade earlier than the Western population, despite having the lower level of LDL cholesterol. It has been reported that more than 50% of CAD associated death in India occur before the age of 50 years and 25% of MI occur before the age of 40 years. In the Inter-Heart study, the median age of MI among Indian was 53 years compared to 58.1 years in the other country. And more recently, in a prospective multi-center trial in India involving 2,153 subjects with acute coronary syndrome, 720 patients were younger than 50 years, which was about 33.4%. Similar findings were reported from a single center large registry from northern India, which recruited 4,672 patients undergoing PCI. In this registry, 31% of subjects had premature or very premature coronary artery disease, which defined as coronary artery disease in men less than 54 years and in women less than 59 years of age. So epidemiology is far different from the Western country. Now, early onset of ASCVD in India has several.
Very premature and premature are the same.
Age only, sir. Premature is less than 54 years and 59.
Very premature is also the same.
No, sir. Less than 45 years. Very premature.
एरर નથી કરી ને
ના ના સર આર્ટિકલ માં આવ્યું સર મેન્શન કરે
ડેફિનેશન છે વેરી પ્રીમેચ્યોર નથી પ્રીમેચ્યોર
yes. So early onset ASCVD in India has several important implications for disease prevention. First, the young age of onset render conventional clinical ASCVD risk assessment tools less relevant in India because in all of them age has an overriding influence on the estimated risk. It also raises question about the relevance of 10-year estimated ASCVD risk and instead emphasize the importance of assessing lifetime ASCVD risk. Second, the high incidence of early onset ASCVD necessitates the early institution of aggressive preventive measure to protect the young population prior to development of ASCVD events. Early treatment yields both short-term and long-term benefits. Results from Mendelian study have clearly shown that even a small reduction in LDL cholesterol achieved at an early age and maintained over decades leads to several fold greater reduction in ASCVD risk compared to more aggressive LDL cholesterol lowering initiated later in the life. Third, lack of awareness among the general public in India of very high risk of early onset ASCVD necessitates the development of strategy for improved detection and treatment of high-risk patients starting at the young age. Now, Lipid Association of India risk assessment algorithm and corresponding recommendation for LDL cholesterol lowering were critically reviewed and updated by the LAI expert panel in accordance with our current understanding of ASCVD risk in Indians and the above issue and concern. Importantly, the recommendation focus on lifetime risk reduction, necessitating early introduction of preventive measure rather than 10-year risk of ASCVD. So, why there is need of accurate ASCVD risk? So, it is required to guide the intensity of lipid lowering therapy and global ASCVD risk reduction. In Western studies, mainly two equations were used to assess, to define the risk category. One was the pool cohort equation, which have been documented to underestimate the risk in South Asia. And moreover, South Asian were not included in that cohort study. So therefore, they are not recommended to use in the Indian subject. Second, Q-risk 3 score, which is better for risk assessment in Indians compared to the pool cohort equation, but a dedicated risk prediction score derived from the Indian population is needed. Development of accurate risk assessment tool require data from large-scale population-specific long-term prospective study examining the strength association between various cardiovascular risk factors and incident ASCVD event in the population. Unfortunately, no such data are currently available for Indians, hence there is no validated ASCVD risk assessment tool for using Indians. Now, recognizing this limitation, Lipid Association India in 2016 developed an ASCVD risk algorithm to guide lipid management in day-to-day clinical practice. This algorithm was based on expert consensus, taking into consideration the high prevalence of ASCVD and its risk factor in India, early onset and complexity of ASCVD among Indians, and the unique social demographic circumstances in India. The previous LAI recommendation have found increased acceptance among various national and international lipid experts and clinicians in India. Now the current recommendation provides updated guidance for ASCVD risk estimation in India based on expert opinion. So categorization based on risk factor or marker. So they have included major ASCVD risk factor like age more than 45 years in males and more than 55 years in female. Second, current cigarette smoking or tobacco use. Third is high blood pressure, and fourth is low HDL cholesterol. So they have included age as the major risk factor.
Less than 45, less than 55.
That is a very high risk group, sir.
More than age, more than 45 or equal to 45, less than 45, less than 55 to more than 45.
More than
age more than
More than
45
major
risk.
risk factor.
45 to ऊपर
Yes, बराबर છે.
गुजराई क्या?
The more than 45 तो it is 60, 65, 70 થઈ ગયું.
It's major.
तो less than 45 ને ISD થાય તો it is the major risk factor.
ना आ
ના
risk
ના ના
factor
risk assessment છે, risk assessment.
assessment છે risk assessment.
Second, high risk feature, family history of premature ASCVD, CKD stage 3B or 4, apolipoprotein B level more than 130 mg per deciliter, extreme elevation of a single risk factor, lipoprotein A more than 50 mg per deciliter, metabolic syndrome, non-alcoholic fatty liver disease with fibrosis, grade 2 or 3 fibrosis, and coronary artery calcium score 1 to 19 and less than 75th percentile depending upon age, race and ethnicity. Third one is the risk modifier, which include the lipoprotein A level 20 to 49 mg per deciliter. Second, impaired fasting glucose level 100 to 125 mg per deciliter. Increased waist circumference more than 90 cm in men and more than 80 cm in women. High sensitive CRP level more than 2 mg per liter. Plasma triglyceride level more than 150 mg per deciliter fasting or more than 175 mg per deciliter non-fasting. Rheumatoid arthritis, psoriasis and spondyloarthritis like inflammatory condition, premature menopause, preeclampsia, gestational diabetes, polycystic ovarian syndrome, high polygenic risk score, air pollution and HIV infection, which are the risk modifier.
So major ASCVD risk factor માં metabolic syndrome અથવા sugar નો એક બી point નથી.
ના સર, મેજરમાં નથી.
તમે મિસ નથી કરતા ને?
ના સર.
રોનક સાચું છે?
હોવું જોઈએ ડાયાબિટીસ નો તો
Diabetes તો risk હોવું જોઈએ.
હા સર, risk factor major risk category
હા,
જાઓ
category
તો
આવશે.
Agreed, પણ risk factor માં બી ના આવે.
હા આવી શકે છે.
અને આ જે હાઈ રિસ્ક ફીચર્સ છે એમાં 8મો પોઈન્ટ છે કે કોરોનરી આર્ટરી કેલ્શિયમ સ્કોર 1 to 99 and less than 75th percentile. Less than 75th percentile explain કરો.
Sir, they have given the percentile score depending upon age, race and ethnicity from multi-center study.
What is that?
So they include article score.
So એ કોરોનરી આર્ટરીના કેલ્શિયમના સ્કોર પર જ છે ને?
Score પર છે.
તો આંકડો તો જોઈ લેવાય ને દોસ્ત કે આટલું less than 75 એટલે શું થાય છે on an average એજ પ્રમાણે એટલું તો you should have it, right?
So categorization in different risk group. Low risk is 0 to 1 major ASCVD risk factor, LDL cholesterol 100 to 129, non-HDL cholesterol 130 to 159 mg per deciliter, which has lifetime CVD risk of less than 30% in the low risk group. Moderate risk consists of two major ASCVD risk factor or LDL cholesterol 130 to 159, non-HDL cholesterol 160 to 189, low risk group with one or more risk modifier or and lifetime ASCVD risk of more than 30%. high risk group consists of 3 or more major ASCVD risk factor, LDL cholesterol 160 to 189, non-HDL cholesterol 190 to 219 milligram per deciliter, diabetes with 0 to 1 major ASCVD risk factor or 2 major ASCVD risk factor plus 1 or more risk modifier or any one high risk feature which are included in the high risk group. Fourth one is the very high risk group, which include diabetes with target organ damage, diabetes with 2 or major ASCVD risk factor, coronary artery calcium score 100 to 299 or more than 75th percentile if coronary artery calcium score is 1 to 99. 2 or more high risk feature establish ASCVD obstructive or non-obstructive, heterozygous familial hypercholesterolemia or LDL cholesterol more or equal 190 milligram per deciliter. And extreme high risk is divided into category A, B and C. Category A include established ASCVD with one or more feature of the high risk group, while category B include ASCVD established with one or more feature of very high risk group. In category A also include coronary artery calcium score more or equal than 300 and homozygous familial hypercholesterolemia. And category C include recurrent ASCVD even despite LDL cholesterol around 30 mg per deciliter, which requires special consideration. They are included in the category C.
So this categorization you will imply after which age? 20, 25, 40 or in all adults?
Most guidelines include after 30 years you should evaluate.
લખ્યું છે એવું?
Guidelines
માં લખ્યું છે? તો કદાચ કોઈ 25 years નો આવે અને એને આ બધા રિસ્ક ફેક્ટર હોય, બરોબર છે, જેમ કે એ હાઈ રિસ્ક માં આવે છે પણ 25 એજ છે, તો તમે કઈ કેટેગરી મૂકશો?
So depending upon that risk factor we can include
રિસ્ક ફેક્ટર તો કહી દીધા કે હાઈ રિસ્ક માં જ આવે છે પણ એજ 25 છે, તમે કીધું ના 30 પછી ઇમ્પ્લાય થાય, તો 25 વાળાને કે 19 યર નો આવ્યો તો એને કેમાં મૂકશો?
તમારે LDL લેવલ કોણ હોમોઝાયગસ ફેમિલિયલ હાઇપરકોલેસ્ટેરોલ તો બધી એક્સ્ટ્રીમ રિસ્કમાં આવી
ના એટલે ફેમિલિયલ હોવો જરૂર નથી, તો ટાઈપ 2 વાળા બહુ રૂટીનલી આવે છે 22 પછી 18 19 વર્ષે, બરોબર છે, એનો LDL 130 140 હોય પણ વિથ ડાયાબિટીસ ઇઝ ઓબેસ, રાઈટ? બટ હવે આ કેટેગરી જે તમે કહો છો કે 30 પછી લાગુ પડે, તો 30 નીચેના પર શું કોમેન્ટ છે એ પૂછું. આ જ બધું છે પણ કોમેન્ટ શું છે? નથી શ્યોર?
Consider all adults.
હા, that is what I wanted to hear. આ બધા 18 પ્લસ ના આમાં હશે. Such an extensive categorization there must include all
એવું
adults.
છે કે 18 onwards ચાલુ કરવાનું છે. Screening also should be started from 18 onwards.
You have this PDF?
Applicable 18
PDF છે ને? Please share with me.
So important changes in the Lipid Association of India atherosclerotic cardiovascular diseases assessment recommendation. So they have included family history as the high risk, which include first degree relative less than 55 years of age, and in a female first degree relative less than 65 years of age. Subclinical atherosclerosis. Many different tools are available for assessment of subclinical atherosclerosis, but quantification of the coronary artery calcium score using CT imaging and assessment of carotid and femoral arterial plaque using ultrasound have been the most studied and validated. Ankle brachial index screening for detecting peripheral arterial disease is also a useful tool for assessing subclinical atherosclerosis with a low ankle brachial index less than 0.9 diagnostic of peripheral arterial disease.
So આમાં minor plaque भी આવે CT coronary angiogram, that is also subclinical, right? So એમાં भी કઈ specific
Yes, sir.
points છે?
Subclinical atherosclerosis. So coronary artery calcium score, which they are using for the subclinical atherosclerosis, individual with age 30 years or above, in which coronary artery calcium score is equal to 0, then we have to categorize the risk and lipid target as per the LAI risk algorithm. If coronary artery calcium score is 1 to 99, then we have to go for the percentile. If percentile is less than 75th for age, gender and ethnic group, then we have to consider them as the high risk group, and we have to target LDL cholesterol less than 70 mg per deciliter.
It's very important, કારણ કે majority આમાં આવે છે અત્યારે.
Yes. And if score is 1 to 99 and it is above the more or equal 75th percentile for age, gender and ethnic group, they are considered as the very high risk group, and in which LDL cholesterol target should be less than 50 milligram per deciliter. Similarly, coronary artery calcium score 100 to 299 is also included in the very high risk group, and coronary artery calcium score more or equal 300 are included in the extreme risk category group A, in which LDL cholesterol target should be less than 50 milligram per deciliter, and in optional target less or equal 30 milligram per deciliter.
So in other words, you
what
can
if calcium score comes high,
Yes.
so you go for angiography. So suppose the angiography detects insignificant
Then we have
coronary artery disease, then
we have to target the
1 to 99
Target
percent.
LDL.
NDL you have to target as a primary prevention.
See, that clearly means કે તમારી પાસે 31 વર્ષનો કોઈ માણસ હોય, બરોબર છે, અને એનો કોરોનરી કેલ્શિયમ સ્કોર હાઈ હોય, રાઈટ, એને જીવનમાં કોઈ પણ ઇવેન્ટ નથી થઈ, then he is extreme high risk still, બરોબર છે, કારણ કે 31 માં શું થાય કે ભાઈ રિસ્ક કેટલું છે, તને તો કંઈ થયું નથી, અનફોર્ચ્યુનેટલી જો એને ફેમિલી હિસ્ટ્રી બી ના હોય તો બી આપણે નિગ્લેક્ટ કરીએ, રાઈટ, this patient is very likely to end up with acute coronary syndrome. When our target is less than 50, it's very tough to explain them the ideal 50 ની નીચે લાવવાનું.
So lipid target depending upon the risk category. In low risk group, LDL target is less than low risk and moderate group target of LDL cholesterol is less than 100, non-HDL cholesterol less than 130, and ApoB protein level less than 90 milligram per deciliter. In high risk group, LDL target is less than 70 and non-HDL cholesterol is less than 100. In very high risk group, LDL target is less than 50 and non-HDL cholesterol level should be maintained less than 80. Extreme risk group category A, in LDL cholesterol target is less than 50 and non-HDL cholesterol less than 80. While in category B, it is LDL cholesterol should be less or equal 30 and non-HDL cholesterol level should be less or equal 60 milligram per deciliter. And in extreme risk category C, in which after optimal use of maximum statin therapy and still patient have developing recurrent ASCVD, then target should be around 10 to 15 milligram per deciliter LDL cholesterol level and non-HDL 40 to 45 milligram per deciliter.
So in other words, if you are an adult, an Indian adult, right, તો તમારામાં LDL 130 નો ટાર્ગેટ હવે છે જ.
Even for asymptomatic, it's not.
Okay, so this should be very categorically spoken.
So a blood sample for lipid profile should be sent, including apolipoprotein B level and lipoprotein A if not already done. Stratify the ASCVD risk according to LAI risk algorithm and define the LDL cholesterol target level. After dividing different risk group, we have to target the LDL level. In low and moderate group, more or equal 100 milligram cholesterol LDL cholesterol level. Then we have to first lifestyle intervention in low risk group, and even after lifestyle intervention, LDL cholesterol level remain above the 100 milligram per deciliter. Then we have to start low intensity or moderate intensity statin level, statin in low risk group with achieving target of LDL cholesterol less than 100 milligram per deciliter. In moderate risk group, in which LDL cholesterol is more or equal 100 milligram per deciliter, along with lifestyle intervention, we also have to introduce moderate intensity or high intensity statin. And if LDL cholesterol is even after starting the statin remain above the 100 milligram per deciliter, then we have to switch over high intensity statin plus or minus azetic, and we have to target LDL cholesterol less than 100 milligram per deciliter. In high risk group, all patients need to be initiated on statin therapy. The intensity of treatment and need for additional drug defined by the risk category and the desired magnitude of LDL cholesterol lowering. So on week 0, on the day of evaluation, we have to calculate the reduction of LDL cholesterol required, and we have to start LDL cholesterol lowering drug accordingly. And fibrate are indicated only if triglyceride level is more than 500 milligram per deciliter at the initial level. On week 4, we have to repeat the lipid profile with FOB and with continue with the same treatment if goals are achieved. Otherwise, we have to introduce additional lipid LDL cholesterol lowering drugs, and if triglycerides remain above 150 milligram, then we have to add icosapent ethyl. On week 8, repeat lipid profile with FOB. If all targets are met, continue with the same treatment and follow up regularly to maintain them. Otherwise, we have to go for the next step, in which add the remaining available LDL cholesterol lowering drug. Familial hypercholesteremia should be considered and aim to achieve LDL cholesterol, non-HDL cholesterol and FOB target as the earliest, depending upon the risk group. In high risk group, target LDL is less than 70, very high risk group less than 50 milligram. In extreme risk category A, target LDL cholesterol is less than 50 milligram, and in extreme risk group category B, target LDL cholesterol is less or equal 30 milligram per deciliter.
So it's crystal clear, right? I have one question here. Triglyceride is more than 500 kilo. Fasting or non-fasting?
Anything, so fasting or not. They have included non-fasting or fasting lipid profile.
Are you sure?
Yes, sir.
They recommend non-fasting.
Non-fasting.
So the basic concept is that I may be wrong, you can correct. જો તમારું fasting, non-fasting તમારી OPD માં patient है અને તમે lipid profile જોઈ લીધું. If your triglyceride comes more than 400, then you need to recheck in fasting set, and then you define the targets.
Although they are not said, but this is true.
We have to. કારણ કે બની શકે કોઈ ઓવરઈટ કરીને આવ્યો તો 300, 500, 800 તો એમને મારું જશે. તો તમારા ટાર્ગેટ બધા બદલાઈ જશે નહીં. Then you repeat in fasting state. હા, LDL માં બહુ ફરક નહીં પડે, પણ non HDL અને TG will be very much affected, right? So what is the role of non HDL? At what triglyceride level your LDL becomes irrelevant?
More than 1000.
More than 400.
What is the importance of the triglyceride divided by HDL ratio?
Risk categorization.
Now they say if the ratio is more than 4, then it considered to be a small dense particles. So it is more atherogenic. And if ratio is less than 2, then it is considered to be a large LDL particles.
Less than 2 તો સાહેબ શક્ય જ નથી, કારણ કે HDL તો 30, 40, 50 હોય. ટ્રાઇગ્લિસરાઇડ તો 150, 200 કરતા વધારે જોવાનું.
તો જ આવે less than 2. Otherwise, in between it's a moderate risk.
જોઈ લેજો નેક્સ્ટ ટાઈમ સાહેબને જણાવો.
બીજું જસ્ટ કે ફાસ્ટિંગ ટ્રાઇગ્લિસરાઇડ ઇક્વિવેલન્ટ ટુ નોન ફાસ્ટિંગ ટ્રાઇગ્લિસરાઇડ એવું કંઈક પીછે ઇક્વેશન
No, no.
ના ના, not possible, not ever.
એવું મૂકેલું છે
Nah, it is not possible. Unless your metabolic rate is so high. Otherwise, triglyceride તમારું જમ્યા પછી વધારે આવે છે.
Lipid targeting acute coronary syndrome with patient on statin patient group A. So they have recommended on admission send blood sample for extended lipid profile including lipoprotein A at the emergency trials. Stratify the ASCVD risk according to LAI risk algorithm and define the LDL cholesterol target. On admission, we have to start or continue.
So, is it this is reliable when patient is come with acute coronary syndrome? Is there any chance that there is a difference in the your lipid levels?
Yes.
Why?
Triglyceride level may be affected depending upon the.
ચલો એક ફાસ્ટિંગ એને રીતે બીજું કઈ છે કે કદાચ આજે મને એટેક આવ્યો પણ મારું 1 month પહેલા લિપિડ પ્રોફાઇલ જોયું હતું ઈ અને એટેકના દિવસે લિપિડ પ્રોફાઇલ જોયું એમાં શું ડિફરન્સ પ્રેક્ટિકલી હોઈ શકે અથવા થિયરિટિકલી કારણ કે 1 month પહેલાનું તો નહોતું આપણી પાસે એમ સમજીને ચાલો તો વોટ ડિફરન્સ ઇટ કેન મેક આમાંથી કોઈ લિપિડ પ્રોફાઇલ નથી કે એક્યુટ ફેઝ રિએક્ટન્ટ છે.
They have included lipoprotein, ApoB, both and HSCRP also they have included.
So will it affect in acute phase એ ડિફરન્ટ થઈ જશે ને? ઓકે પણ છતાં આ લોકોએ લખ્યું છે કે ત્યારે જોવાનું. Good.
See, I don't know, in an acute MI, I have seen a number of patients where your cholesterol is normal, LDL is also normal. I don't know.
So what was the idea of doing, the lipid profile at the time of ISD? Suppose the LDL cholesterol comes at that time 200. 200, that means whatever oral therapy are you going to give is not going to reduce LDL less than 100. So you have to start PCK9 inhibitor right on that day. On that day, so that after 4 weeks, 8 weeks, you will see that the LDL started reducing. The idea of doing lipid profile at the time of ISD is to see the LDL level, then whatever this high intensity statin, ezetimibe, rapid oil, that is going to reduce 50%. Suppose 140 LDL share, that means it will reduce 70. So you need not give any additional treatment at that point of time. And after 3 months you re-evaluate. Even if the target is not achieved, you have to again, maybe you have to give for inclisiran or PCK9. So the idea of doing that is to prevent further reduced SCVD leaks at the time of acute infarct.
So they have recommended on admission start or continue high intensity statin plus ezetimibe in the group 1, 2 and 3. In the patient with statin intolerance group 4, low dose statin plus ezetimibe should be continued. On receiving lipid profile report in hospital, continue high intensity statin plus ezetimibe and consider additional available drugs like bempedoic acid, bile acid sequestration, PCSK9 inhibitor to reach the target LDL cholesterol level less than 50 mg per deciliter or less or equal 30 mg per deciliter as needed if lipoprotein A level is more than 50 mg per deciliter. And we can also consider PCSK9 inhibitor in which target LDL cholesterol remain above the target level.
Another question was why PCSK9 is not inclisiran during that time. The idea was what I heard is that the PCSK9 acts very fast compared to inclisiran.
Yes.
So give otherwise you in other if there is no emergency you have the choice of inclisiran also.
So they said LAI said inclisiran after 2 weeks of all this. So after 2 weeks of the event, because it's a slow acting.
Slow acting, it is
It is very cost effective. PCSK9 you give every 15 days versus inclisiran you have to give every 6 monthly. So cost is more or less same. PCSK9 20 injection versus inclisiran single injection.
Once the target is achieved, you may switch over from PCK to inclisiran.
Yes.
Then
So will you give ezetimibe in a statin naive patient who is coming with MI?
yes sir, they have recommended to give statin plus ezetimibe in the ACS.
આ જે ચાર્ટ આપ્યો છે એમાં ક્લિયર
Direct ezetimibe. Sir say direct ezetimibe without statin.
statin naive patient comes with MI. Will you give statin and ezetimibe or will you give only statin?
In ACS they have sir mentioned statin plus ezetimibe.
Again, you
Last
see
part
the
is
LDL target.
ઉપરના ગ્રુપ સાથે એનો શું સંબંધ છે બહુ ક્લિયર નથી થતો.
If your LDL target is not going to achieve with 40 milligram of rosuvastatin or 80 milligram of
પણ એ તો આપણે 1 month પછી જશું ને આપણે તો ઓન એડમિશન વાત કરીએ છીએ.
the admission ની વાત છે.
But in general, statin high intensity will reduce LDL by 50%. Later on, if you don't achieve target, we'll add ezetimibe.
That is all theory. આમાં આ શું કહેવા માંગે છે?
આ એવું
સ્ટેટિન
direct
નાઈવમાં છે,
starting
સ્ટેટિન
start
નાઈવમાં એમાં આ નીચેનું સ્ટેટમેન્ટ લાગુ પડે છે.
હા જો સરે કીધું
આપી
એ
દેવાનું.
પ્રમાણે 200 પ્લસ LDL આવે તો યસ એઝિડિમિબ ડે 1 થી પણ સ્ટાર્ટ કરવી જોઈએ.
એટલે આને એડમિશન જ ચાલુ કરવાનું.
ચાલો,
હા 200 પ્લસ આવે તો
you have
યસ.
to say by combining the three, what will be the reduction of LDL? If after 3 months it is going to, you are going to achieve 70 milligram, so you continue
That
with
is fine. That
20.
is all our understanding. હું આમાં પૂછું છું આ શું કહેવા માંગે છે. એટલે from day 1 onwards your all patient must be on ezetimibe. That is what the conclusion.
Yes sir. They have mentioned in guidelines like that.
ઓકે એટલે ઇન્ડિયન પેશન્ટ એમઆઈ લઈને આવે સ્ટેટિન પર હતો નહોતો હાઈ હતું લો હતો ઇન્ટેન્સિટી ગમે તે હતી આપણે એઝેટિમિબ આપવાની જ છે એવું કહેવા માંગો છો તમે
Guidelines.
ગાઈડલાઈન એવું કહે છે ઓકે
Even low dose statin plus એસિડિમેટ લાસ્ટ કોર્નરમાં પણ ઓન
હા
એડમિશન
એ તો પેલા ઇન્ટોલરન્સ વાળા ગ્રુપમાં છે.
એટલે બધામાં ઓન એડમિશન તમારે એક્યુટ કોરોનરી સિન્ડ્રોમ હોય તો ઇન્ડિયન ઓરિજિનને તમારે એસિડિમેટ
આપી દેવાનું.
ચાલો એસિડિમેટ વાળી કંપનીમાં ઇન્વેસ્ટ કરો.
Then we have to repeat the extended lipid profile at 2 weeks. If LDL cholesterol is target, then continue the
Suppose the another query was that, suppose that patient on admission, LDL level is just 80-90. So what amount of will you give? What amount of that atorvastatin or rosuvastatin will you give?
Still,
એક્યુટ કોરોનરી છે એટલે હાઈ ઇન્ટેન્સિટી તો આપવી જ પડશે.
હાઈ રિસ્ક જ થયું હાઈ
even for
Very
this
high risk.
plaque
Yes,
stabilizer,
For mark
laboratory-
stabilization you give high.
Yes.
Where you have to consider not LDL level, but you have to stabilize the surface.
Stabilize.
Yeah, but still ezetimibe has to be given according to your guideline આ જે છે right? જેમ કે 70-80 LDL લઈને આવ્યો તો હાઈ ઇન્ટેન્સિટી સ્ટેટિન પર એઝેટિમિબ તો આપવાનું છે.
If LDL cholesterol target are not achieved at the end of 2 weeks, then we have to use additional available lipid lowering drug like pampoidic acid, bilateral sequence, PCSK9 inhibitor. Then we have to repeat at lipid profile at the 4 week, and if target are not achieved, then we have to add the additional lipid lowering drug. Consider adding newer lipid lowering drug, and in selected cases lipoprotein apheresis if LDL cholesterol not at goal despite PCSK9 inhibitor. So in ACS patient, a non-fasting lipid profile is acceptable as the goal is to achieve LDL cholesterol below 55 mg per deciliter as early as possible. A proven concept in LDL cholesterol management in ACS, it early with combination lipid lowering therapy. High dose statin alone may not be able to attain the LDL cholesterol goal in a significant number of patients. Therefore, addition of ezetimibe at initiation of treatment is recommended. It is recommended to add another non-statin drug if LDL cholesterol target of less than 55 mg per deciliter is not achieved at the 4th week. Choice are pampoidic acid, PCSK9 inhibitor or inclisiran. Triglyceride level target. If triglyceride level is 150 to 499, then we have to target to achieve the LDL cholesterol level and non-HDL cholesterol level. Treatment for triglyceride level is initiated if triglyceride level is more than 500 due to increased risk of pancreatitis or ASCVD. So in triglyceride level 150 to 499, we have to start the lifestyle intervention in all patients with low fat diet, avoid refined carbohydrate, weight reduction, exercise, avoid alcohol and smoking. Along with it, we have to control the secondary cause of hypertriglyceridemia like diabetes. If after that lifestyle measurement, LDL cholesterol level, non-HDL cholesterol level remain high, and with patient with high risk of ASCVD risk, then we have to initiate the statin plus or minus ezetimibe to achieve the LDL cholesterol target. In triglyceride level 200 to 499 mg per deciliter, after the lifestyle intervention, we have to initiate statin plus or minus ezetimibe. And if triglyceride or non-HDL cholesterol remains still high, consider fibrate omega-3 fatty acid, preferably icosapent and ethyl. If triglyceride level more than 500, then we have to, along with lifestyle intervention, we have to start medication for all patients, like fibrate omega-3 fatty acid. If and after that, initiate statin plus or minus ezetimibe to achieve LDL cholesterol target if high LDL or high ASCVD risk. And if triglyceride levels still remain high, then we have to consult lipid specialist, genetic testing, and newer drug may be required to maintain the triglyceride level. If triglyceride level more than or equal 1000 mg per deciliter, then treatment should be started in all patients due to risk of pancreatitis. So they have included if less than 500 triglyceride, we have to first target to achieve the LDL cholesterol level. After that LDL cholesterol level, if still remain high, then we have to introduce the fibrate to achieve the LDL cholesterol target.
So this triglyceride we are talking is fasting triglyceride.
Yes.
Being the Indian drug, the saroglitazar is not mentioned here.
No sir, as it is there.
Saroglitazar is not in this, but there is a special mention in diabetic patients.
But I think it reduces
It
triglyceride
reduces, yes, yes.
extensively compared to
Yes.
vibrate. It reduces.
પણ એ ડાયાબિટીક કેટેગરીમાં જ આવે છે એવું છે. નોન ડાયાબિટીકમાં નહીં.
Diabetic and fatty liver.
હા ફેટી લીવર પણ ફેટી લીવરની ગાઈડલાઈનમાં પાછું નથી મૂક્યું આપણે.
ના ગાઈડલાઈન માં નથી પણ આ તો
આપણે વાપરીએ છીએ અલગ.
In patient with diabetes, they have divided into two categories: diabetes with no ASCVD, and second is diabetes mellitus with established ASCVD. If diabetes mellitus with no ASCVD and no target organ damage with 0 to 1 risk factor, then they are categorized into the high risk group, in which LDL target should be less than 70 and non-HDL should be less than 100 and ApoB level should be less than 80. If diabetes mellitus with no ASCVD with target organ damage or 2 or more ASCVD risk factor, then we have to categorize in very high risk group, in which LDL cholesterol target should be less than 50, non-HDL should be less than 80 and ApoB level should be less than 65. So at the time of diagnosis of diabetes, and lipid profile including ApoB and lipoprotein A level, start LDL cholesterol lowering drug as per percentage reduction of LDL cholesterol required. Add fibrate if triglyceride level is more than 500 mg per deciliter. On 4th week, repeat lipid profile with ApoB. Continue with the same treatment if goals are achieved. If not, then depending upon the LDL cholesterol reduction required, additional LDL cholesterol lowering drug should be administered. If triglyceride level remain above 150 mg per deciliter, then we have to add icosapent. On 8th week, repeat lipid profile with ApoB. If all target are met, continue with the same. If not maintained, then add remaining LDL cholesterol lowering drug, and familial hypercholesterolemia should be considered in that patient, and achieve to LDL cholesterol, non-HDL and ApoB target at the earliest. Make sure all modified risk factors are controlled, including diabetes, control and aggressive lifestyle intervention. SGLT2 inhibitor and GLP-1 receptor antagonist may be considered if not contraindicated.
So that clearly suggests an adult with type 2 diabetes without any other risk factor, his or her target LDL is 70 because he is automatically in high risk.
High risk group. So extreme high risk category C, in which recurrent cardiovascular event occur despite LDL cholesterol is around 30 mg per deciliter, in which myocardial revascularization if indicated, aggressive lifestyle management, effective control of all modifiable risk factor, and one or more of the following is as appropriate. SGLT2 inhibitor and GLP-1 receptor antagonist for metabolic residual risk, icosapent ethyl if elevated triglyceride more than 150, colchicine 0.5 mg per deciliter if HSCRP is more than 2 mg per liter. Dual antiplatelet therapy including ticagrelor or aspirin with low dose rivaroxaban for residual thrombotic risk. If again recurrent cardiovascular event happen after despite this measure, consider further lowering of LDL cholesterol to around 10 to 15 mg per deciliter. Now, management wise, statin in the dyslipidemia are the drug of choice, have proven potential protective effect in on clinical situation like primary prevention, secondary prevention, following revascularization, diabetes, and patient with homozygous familial hypercholesterolemia. Observation study have suggested that South Asian and Indian are hyper-responder to statin and may require lower dose to achieve the same effect. This group may also be more susceptible to statin-induced adverse effect. Statin are effective, useful in lowering total and LDL cholesterol and triglyceride in high dose. Effects are dose dependent and the lipid lowering efficacy vary for different statin. Rosuvastatin, which is water soluble, and atorvastatin fat soluble, are considered the most potent statin, and lower dose of this agent are considered as moderate intensity statins. So depending upon dose, they are divided into high intensity, medium intensity and low intensity. So if target is more than 50% LDL reduction, we have to start with the high intensity statin, which is atorvastatin 40 to 80 mg and rosuvastatin 20 to 40 mg. If target is 30 to 50% LDL reduction, We have to start with the medium intensity statin, atorvastatin 10 to 20 and rosuva 5 to 10 mg. And with low intensity, in target less than 30% LDL reduction, we can start with low intensity atorvastatin 5 mg. Newer lipid lowering agent ezetimibe, bempedoic acid, PCSK9 inhibitor and inclisiran can be combined with statin and have multiplicative effect. In general, statin are safe and well tolerated but associated with muscle and liver toxicity, and this should be promptly detected and treated. Reduction of the dose, temporary withdrawal of with careful reintroduction or changing at lower potency statin may help. Statin are contraindicated during pregnancy and breastfeeding and not recommended in premenopausal patients with or without diabetes who are considering pregnancy or not using adequate contraception. Traditional and novel non-statin lipid lowering drug ezetimibe, statin ezetimibe combination is recommended to achieve LDL cholesterol target early after the acute coronary event. It also useful in combination with statin in heterozygous familial hypercholesteremia as initial therapy. Ezetimibe may be used alone, which reduce 50% LDL cholesterol, or in combination with bempedoic acid, which reduce around 40% reduction in LDL cholesterol in statin intolerant patients. Bempedoic acid added to maximum tolerated statin therapy, approved to lower LDL cholesterol in adult with primary hypercholesteremia or mixed dyslipidemia, heterozygous familial hypercholesteremia in patients with ASCVD who require additional lowering of LDL cholesterol despite on maximum tolerated dose of statin or statin plus ezetimibe. It is also indicated either alone or in combination with ezetimibe in patients who are statin intolerant. Alone, bempedoic acid reduces LDL cholesterol by around 25%. The risk of myopathy is also low, but no increase in new onset or worsening of diabetes is observed with the bempedoic acid. There is mild but clinically relevant increase in serum uric acid level with use of bempedoic acid.
Those who have used, they said there is a significant increase in uric acid in Indian patients. That is what I have heard.
Clinically relevant increase.
I use. It increases.
કેટલું
But
બાકી
also
છે?
it's asymptomatic.
थोड़ा 5-6 slides. PCSK9 inhibitor which reduce LDL receptor clearance, increase the hepatic LDL receptor density that result in increased hepatic uptake and lowering of LDL cholesterol. Evolocumab and alirocumab are approved for the clinical use. In India, evolocumab is presently available and which reduce LDL cholesterol by around 50 to 60%. Evolocumab is available as subcutaneous injection to be administered at 140 mg every 2 weeks or 420 mg once a month. They are generally well tolerated with few side effects. They are indicated in patients with established cardiovascular disease or high risk of cardiovascular event or in familial hypercholesteremia. They are used to reduce LDL cholesterol below 70 mg per deciliter in high risk patient or maximum tolerated dose of statin and or ezetimibe who fail to reach the target. They have been proven to reduce the risk of major adverse cardiovascular event in patients with cardiovascular disease, especially post-acute coronary syndrome or stroke. They are very efficacious but expensive, and they should be used in those who are most likely to benefit, like very high risk population.
પ્રાઇસ શું છે ત્યારે એમઆરપી એવોલ્યુકમિબ 15 18 120 વાળો 140 વાળો
यूज करो
Yes.
બોલો લી આવું કેવું ઇન્ટેન્સિવિસ્ટ વાપરે ને કાર્ડિયોલોજી
OP રોડ પર વાપરો.
અચ્છા ઓકે
હું બેમ્પેડોઇક એસિડ કામ છે.
તમે આયુષ્માન વાળા આયુષ્માન
Inclisiran is long-acting small interfering RNA that inhibit the transcription of PCSK9, which result in decrease in PCSK9 generation in hepatocyte and increase the LDL receptor expression in liver cell membrane, leading to about 50% reduction in serum LDL cholesterol level. They are administered subcutaneously 284 mg twice a year and has potential of better compliance. They are associated with 24% lower rate of major adverse cardiovascular event with no increase in unwanted side events. Result of major outcome trials are awaited. They improve the compliance and causes less LDL cholesterol variability.
એની કેટલી
ઇવોલોકુમેબ કેટલું મેસ રિડક્શન કરે?
1 લાખની ઉપર છે.
ઇઝરાયલી કેટલી
1 લાખની ઉપર છે.
1 લાખની ઉપર 1.2 to 1.5 lakh.
ઇવોલોકુમેબ કેટલું મેસ રિડક્શન
એ
કરે?
વાંચ્યું છે મેં નહીં
Reduction.
હા
It's around 50%.
નહીં તો એલડીએલ કોલેસ્ટ્રોલ મેસ રિડક્શન કેટલું કરે છે? આમાં તમે ઇન્ક્લિસેરનમાં કેમ કીધું કે 24% મેજર આઉટકમ એડવર્સ ઇવેન્ટ અફેક્ટ રિડ્યુસ કરે છે, આમાં ઇવોલોકુમેબ કેટલું કરે છે?
This is the exact
નથી.
Fibrates are indicated as monotherapy if fasting serum triglyceride is more than 500 mg per deciliter, primarily to reduce the risk of acute pancreatitis. And fibrate monotherapy offer only a modest reduction in cardiovascular event without no reduction in stroke, cardiovascular mortality or total mortality. Combination of fenofibrate and statin in patient with type 2 diabetes may yield better outcome in management of mixed dyslipidemia. Fish oil, icosapentaenoic acid and docosahexaenoic acid reduce serum triglyceride level around 25%, but they may mildly increase the LDL cholesterol level. So, and icosapentaenoic acid in large dose may have cardioprotective effect. Randomized trial of high dose icosapentaenoic acid are inconclusive, and highly purified icosapentaenoic acid showed significant reduction of major cardiovascular event. Clinical use of this omega-3 fatty acid from dietary supplementation is limited by large number of capsules required to achieve the triglyceride doses, reducing doses. Alpha linolenic acid concentrate have no significant benefit on cardiovascular outcome. Bile acid sequestration, they reduce LDL cholesterol about 20%, but attenuate the hypertriglyceridemia. They have limited use due to poor tolerance and better efficacy of statin. They are used as the second line lipid lowering agent in patients who cannot tolerate high dose statin or in subjects whose target level are not achieved with statin monotherapy. Triple therapy with statin, ezetimibe and bile acid sequestration is effective in many patients with heterozygous familial hypercholesterolemia. They are the only lipid lowering class that is safe for women planning pregnancy or during lactation.
that is the most useful last sentence
What is the issue with that? GI side effect.
GI side effect.
Already woman બિચારી પ્રેગ્નન્ટ હોય એમાં ભૂકા બોલે. વાપરો છો તમે કોલેસ્ટેરોલ?
Lomatipide lower the level of all ApoB containing lipoprotein, including very low density lipoprotein LDL and chylomicron by inhibiting the MTP enzyme. It causes significant reduction in both LDL cholesterol and triglyceride. It is approved for the treatment of adult patients with homozygous familial hypercholesterolemia. Close monitoring for hepatotoxicity is required. Mipomersen is single-stranded synthetic antisense oligonucleotide which affect the production and secretion of ApoB containing lipoprotein with demonstrated efficacy in both heterozygous and homozygous familial hypercholesterolemia patients, but response is variable and there is the risk of hepatotoxicity. So it is approved in the US for restricted use in the homozygous familial hypercholesterolemia. And measurement of non-HDL cholesterol is simple, more convenient and more predictive of ASCVD than the LDL cholesterol, but less often used because LDL cholesterol is more widely used in the randomized controlled trial and international guidelines. But we have included non-HDL cholesterol as co-primary target in our guidelines. Therapeutic strategy directed at increasing HDL cholesterol have not been shown to improve cardiovascular outcome and are not recommended by the guidelines.
Very important point.
How lifestyle changes known to increase HDL cholesterol should be encouraged. This includes weight reduction, aerobic physical activity like brisk walking, smoking cessation, dietary modification, including reducing carbohydrate intake. Apolipoprotein B as an ideal biomarker. It is critical structural component of the atherogenic lipoprotein. A single ApoB molecule is present in every particle of VLD, IDL and LDL and lipoprotein A, but not in the HDL cholesterol. So it is direct measure of circulating atherogenic lipoprotein and can be measured more accurately than the LDL particle. Several large epidemiological studies indicate that apolipoprotein B and A1 are better predictor of ASCVD than total cholesterol, LDL cholesterol and non-HDL cholesterol. Genetic studies showed that high level of ApoB correspond to high level of LDL cholesterol and non-HDL cholesterol and are associated with increased risk of CVD. So, conclusion: effective lipid lowering therapy, lowering through non-pharmacological and pharmacological measures should be one of the important strategy for ASCVD prevention. Selection of modality and intensity of lipid lowering therapy and identification of treatment target depend on the patient's future risk of developing ASCVD. Hence, accurate assessment of ASCVD risk is essential first step to guide the intensity of treatment, including the lipid management. Updated risk assessment algorithm presented is intended to help clinicians select appropriate lipid lowering treatment regimen, optimal lipid goal, and comprehensive risk reduction in their patient, thereby improving cardiovascular outcome. Although this recommendation provides solid guidance for cardiovascular risk assessment and lipid management in Indian patients, clinical judgment and shared decision making remain important at every step in applying this recommendation in clinical practice.
Young patient